So I am a plastic surgeon at Walter Reed, so I spend most of my time in the extremity and dealing with nerves. So I'm a little bit out of my element here, but thanks for letting me infiltrate this group. I also want to acknowledge a lot of this work was done by one of my residents, Chris Scheiber, who is probably swimming in a pool right now as he's in dive medicine training. And so why am I talking about this? Well, in the course of my training, I helped develop some of the concepts that have driven this suturable mesh concept, or an actual product at this point. But I have no financial disclosures. I have the same DoD disclosures as everyone else in the room. So we're going to talk about hernia prevention and why it's particularly applicable to the forward deployed setting. Talk about some of the literature that suggests technique modifications that are designed to prevent hernias, and look at some of the biomechanical data behind those technique recommendations. We'll also talk about why we need to look beyond technique and actually look at suture design to kind of get a handle on this problem, which probably is the biggest surgical failure of modern surgical practice in terms of if you think of the amount of surgeries and the amount of hernias that we create. And then we'll look forward and look at some of the other things we're looking into. And so while a lot of our civilian colleagues have used minimally invasive techniques to try to prevent hernia formation, in a forward deployed setting, these are Role 2, Role 3 hospitals, virtually all of the surgery that is done open. So it's going to be prone to hernia formation. One of the problems is the literature on the incidence of hernia formation, particularly in the trauma setting, is very scarce, and it's all over the place. This most recent 9% is from the Brits. They looked at their open management of abdominal trauma. That said, we have to suggest that it's probably as bad as it is in the elective setting, which is somewhere in the neighborhood of 24%. While we tend to have young, healthy patients undergoing trauma, laparotomies, this setting is also not ideal. If you look at some of the literature drives this, everyone here is probably aware of the Stitch trial and Israelson's work with suture to wound length ratio, but every single trauma surgeon I talk to does not use that technique, and the question is why. I was actually just at the American Hernia Society a couple weeks ago, and Hans Jekyll, who's a big name in this, had a presentation called "What's Wrong, America?" Basically, the Europeans are using this, why aren't you? Well, this is one of the reasons. The authors of the Stitch trial say that actually you can't extrapolate this evidence to the trauma setting. This was done in an elective, mostly cancer setting. The other thing that a lot of the trauma surgeons I talk to point to is they say, that's not my population. First of all, that's elective, and these guys are skinny Dutch. You know, we have much fatter patients. It's worth pointing out that the Army is twice as fat as the Navy. But actually, at 8%, we're actually dealing with a population that is much skinnier than our civilian counterparts have to deal with. They're dealing with a population where 75% of their trauma patients are overweight, and so so the results of that Stitch trial can't be generalized to that population. Now, if you look at some of the experience, this basically shows that old habits are hard to break, right? If you look at this on the right, or your right, yep, this is an experience where this was a center that was very much committed to using this suture to wound length ratio of 4:1, and a quarter of the time, even though they tried to do it, they didn't achieve it. And if you look at this survey of residents, 75% of the residents knew that suture to a wound length ratio of 4:1 was ideal, but then they said they prefer to take 1 centimeter bites, 1 centimeter spacing. And so one of the things we're up against is that there is known to be actually a 17-year lag between surgical intervention and introduction or adoption as standard practice. And so we need to think about other ways to overcome that lag. There are other strategies to prevent hernias, and there's good literature out of Europe that prophylactic mesh augmentation is actually a very effective strategy to prevent hernias. The problem is it comes with about a 20% surgical site occurrence rate, and given the kind of challenges of being in the forward deployed setting, using a totally different technique and implanting a lot more material is probably not a reasonable strategy. And so it's worth looking at some of the biomechanical data behind this recommended technique to see if there's other ways we can do it. Interestingly, the only biomechanical study that's referenced in the Stitch trial is this study by Hilar et al. And basically what they did is they just did a straightforward linear pull-through model and demonstrated that small bites had a greater force at failure. The problem is almost half of the failures occurred at the clamp. So is this really a demonstration of efficacy, or is it just a failure of the model? Regardless, because the data supported what they were trying to support, it was used to then bring this into clinical practice. Israelson has done a lot of work on this and has really been important in kind of driving this concept of force distribution. In a rat burst model that I have some experience with, they showed that basically when you use this 4-to-1 ratio immediately, it's actually weaker than a larger bite technique. But in the they retested it 4 days and found it to be stronger. And the idea was that you're able to distribute forces across a greater surface area if you have more suture tissue interface. More recently, there's been some studies out of the UK using kind of much more robust methodology. And what they found is that, yes, it actually has to do with the ratio, but really you only see a significant difference when you get to extremes of ratio. You only really saw a benefit once you were to a 13-to-1 ratio and only saw a weaker repair at essentially a 2-to-1 ratio. And when you compare the 4-to-1 ratio, the small bites technique, to kind of the standard 1 centimeter bite, 1 centimeter spacing that everyone's doing, there's statistically no difference. So other strategies to try to prevent or to achieve force distribution in plastic surgery, we're very familiar with these if you look at all these various tendon techniques. But it begs the question, should we be using the same tool in a different way, or why not just use a different tool and use it essentially the same way? And so that's what really drove this concept of a suturable mesh, is trying to achieve force distribution, not by using the suture that we all know is too sharp to do what it's supposed to do, to actually get force distribution using standard techniques. We're actually behind the curve. The orthopods have totally adopted this. In terms of the sports surgeons, they love these suture tapes, right? They know that an increased aspect ratio of a suture results in decreased pull-through, and there's actually a kind of a veritable competition between orthopedic suture manufacturers to make wider sutures, right? What's the problem with a wider suture? Well, that's a lot more foreign material. The other problem with a wide suture is it has to be oriented. If it's oriented the wrong way, it's no different. If it's oriented on the skinny side, there's no difference than a conventional suture. This is where we kind of, once we were able to show the benefit of a wide aspect ratio, the question we asked when I was kind of helping come up with this concept is, how do you achieve that force distribution without having to orient, and how do you do it with less foreign material? Well, by having a hollow bore mesh suture, basically what happens is when the force is applied to it, it flattens like a ribbon, right? And then by using it, by having it hollow bore and having it macroporous, you can get that benefit. You can get all that surface area to have tissue interface while having very little additional material. The body, we're not going to get into this, but also by making it with small filaments, the body handles small filaments very, very well. It facilitates tissue ingrowth. It actually also clear infection of a small filament much better than a large filament. So we went back to the techniques used by Hilar and all and tried to recreate their data, and we did. And we did it actually with only 4 failures at the clamp. And so that speaks to kind of the power of our, I think, or the assistance from our 3D printers. And what we showed is actually there is a increased force of failure with a small bites technique. But interesting, when you convert to the 2.0 PDS from the number 1 PDS that was then used in the stitch trial, you actually attenuate the benefit. And when we applied our suturable mesh to this concept, we saw that it outperformed all of it. And let's see if this is going to be a challenge here. Oh, maybe this is going to work. So this is just a demonstration of the strategies. And so you can see kind of what you're going to see is just an entirely different pattern of pull-through. I'm using up my remaining seconds here, but it's worth just, a video is worth, what, 1 million words? Okay, get the idea. And so the idea is, rather than use 1 million small sutures in a small bites technique, use a single suture that then allows distribution across a lot of small filaments. The power of this technique is, if you open your mind to changing the design of the suture, you can then change the technique to further optimize it. And that's kind of really where I think we'll see the benefit. I was giving this talk to a hernia audience. The people who fix hernias, do abdominal wall reconstruction, know that suture material and technique are totally dependent independent. You can't kind of tease out the two. So where do we go from here? Well, we've done this linear testing. We've also now already done a multi-axial load model, a ball burst fatigue model, and we're finishing up completion of a pneumatic simulator that we're going to use both for testing and training. We also are about to launch a clinical trial at Walter Reed in shock trauma, where we're going to use this in the setting of trauma. Thank you.